HealthEd is Australia's leading provider of quality clinical education for doctors and other healthcare professionals. This episode has been made available on Spotify and Apple Podcasts. For free access to the full library of podcasts and to claim CPD for listening, visit healthed.com.au or download the HealthEd app.
Do you routinely exclude subclinical hypothyroidism in a woman who has just been found to be pregnant? What are the risk factors that will alert you to do so? How will you initiate thyroxine in the elderly? As GPs, we assess women for postnatal depression all the time. But when was the last time you excluded postnatal thyroiditis? Especially because it can cause symptoms very much like postnatal depression. And is iodine deficiency a real issue in Australia? And if so, what should we be doing about it? In this podcast, I will be speaking to Professor Creswell Eastman. Professor Eastman, tell us about yourself.
And I'm an endocrinologist, come chemical pathologist, and also practice in public health medicine. So a little bit of various specialties, but primarily an endocrinologist and have been for a long time. And my major interest in endocrinology is in thyroid disorders. By way of background, I set up endocrinology services in Canberra in the 1970s and then was lured, I think is the correct word, to come to Westmead to set up endocrinology diabetes services there in the 1980s. I was head of endocrinology and then ultimately took over the Institute of Clinical Pathology and Medical Research as director there for 16 years. And I retired from there a few years ago and have been just running my own private practice clinic since then.
You have just so much experience and knowledge that we can tap into, Chris. Today, we are actually going to be quite focused. We're looking at thyroid replacement medications and hopefully giving our GP listeners a fairly practical advice and tips on how to do it well. So let's start by looking at the various sorts of if you like, thyroid replacement medications. What are available? What are the differences between them?
Thank you, David. Well, I think I might just start by saying that thyroxine monotherapy is the agreed recommended medication for treatment of hypothyroidism. Mm-hmm. There are other things, and we'll come to them in a minute, other forms of thyroid hormone, but the agreed medication is thyroxine and thyroxine alone, and its chemical name is truly levothyroxine. Now, on the PBS, we currently have 4 medications available you can prescribe on the PBS. 2 of them have been there for a long time. They are Eutroxic and Oroxine, made by the company I think is called Aspen. They are essentially the same medication. They come from the same factory, I believe the same ingredients, except that Oroxine is a premium brand, which they charge a little bit more. Mm-hmm. Some patients, as we'll discuss in a moment, think they are different and feel that they do differently on these medications, and they distinguish the difference between them. However, from the PBS point of view and scientific point of view, the TGA has adjudged those medications to be equivalent. Now, there are 2 newer ones. One is Levoxine, which comes from another pharmaceutical company, which is bioequivalent to Eutroxic and Oroxine. So from the PBS's point of view, and I think from many pharmacists' point of view, they are seen as being interchangeable because they're bioequivalent. Mm-hmm. But again, we'll discuss that in a moment because that's not necessarily the view of various thyroid associations and various thyroid patients. Mm-hmm. Now, the disadvantages of Eutroxic and Oroxine are that they must be kept refrigerated at all times because they tend to degrade. Their heat is unstable and they tend to degrade. The newer one, Levoxine, is not unstable and it should be kept below 25 degrees centigrade. And I think most indoors places where one would store your medication would be below 25 degrees. Of course, if not, then you need to store it at a cooler temperature. So that's the newer one on the block.
Mm-hmm.
There is another one, slightly more expensive, that has also only recently come on to the PBS, and that's L-troxin. And again, that comes from the same stable as Utroxic and Oroxine medications from Aspen.
Mm-hmm.
That is not bioequivalent to the other three I've mentioned. It should be treated separately. It's reasonably heat stable. It doesn't need to be refrigerated. It costs a little bit more, and there are various different strengths that you can get. I think it's a good medication because you don't have to store it in a refrigerator. So there are the four. Now, one of the problems we have with talking about bioequivalence is that once a patient has been stabilised on a given brand, I think we all feel that it's best they should stay on that brand if they've been stabilised.
Mm-hmm.
The reasons for that are that absorption may vary from one patient to another, one time to another. Patients have a perception that absorption is different or biological effect is different, even though there are multiple studies showing with these bioequivalent brands, the multiple studies showed that there is no significant difference that we can tell in any sort of randomized controlled trials. Having said that, you learn from your patients, you respect what they have to tell you,
Mm-hmm.
and therefore I think it is very important that once you've stabilized your patient on a given brand of thyroxine, whichever one you choose, then you should try and stick to it, which means that you as a doctor writing out the prescription should do your best to ensure that you write that prescription out in that brand name rather than the generic name, but in the brand name.
Mm-hmm.
And tick the box, brand substitution not permitted. That should be the way we practice. I mean, you may, as an individual doctor and with your patient, decide otherwise. That's fine.
Mm.
But you should, I believe, do that because the Australian Thyroid Foundation gets a lot of complaints from patients saying they went to the pharmacy to get their medication. It was just written as levothyroxine. They weren't given a choice, or they were given a choice. They weren't certain what they should do. And at times they feel that when they have changed brands that things haven't gone well for them.
Mm-hmm.
A lot of those complaints they make are difficult to define, but I think we need to accept them, that that's what the patient feels, and we need to respect it.
Yeah.
So I think most expert bodies agree that we should try, when we're prescribing it, once we've stabilised the patient, we should try and stick to that brand.
Well, that makes a lot of sense for that particular group of patients, Chris. If they are stable, we ought to prescribe the brand name and tick the box so that the pharmacists do not give them generic brands and confuse everybody.
Sure.
I do ask a question though. What about our patients who are not yet stabilized and who have been commenced on, say, one of the older thyroid medications? Should we always ask them, do you always store your medications in the fridge? And if the answer is no, not really, do you think we ought to use that time to then change over while we're still trying to stabilize the patient?
Well, if we want to change over and we think there's reason to change over, that's good medicine. You do that. But I think what you've got to tell the patient is that even though the three that I mentioned are bioequivalent, the other one isn't, it's about 10% biologically different. I think we should explain to them that theoretically all the experimental work says they're bioequivalent. In other words, this one's the same as the other one. Now, you, Mrs. Smith, may find a change. If you do, you need to report it. You need to tell me, your prescribing doctor, about it. So there's no reason why you can't change a patient over. But I think you've got to explain to them that even though the TGA and the experts say they're bioequivalent, in other words, they're the same, they may not act the same way in you. They may not be absorbed the same way in you. And therefore, we should be cognizant of that in the way we manage it. So you, the patient, need to report back to me how you feel. I will manage your monitoring by ordering your appropriate blood tests so that I can see objectively what's happening in your body. I can monitor your physiology. That tells me whether you're doing well or not doing well, and we'll make appropriate changes together. So I think a little bit of explanation and education is the way to go, rather than having a patient standing at the pharmacy counter confused or arguing with the pharmacy assistant or the pharmacist about what they should be doing. So I think it's that good medical practice of informing the patient, not lecturing them, but informing them and trusting them with the decision-making process in the way you manage it.
Again, that makes a lot of sense. Thanks, Chris. I would wonder if I could ask you to follow 3 patients forwards, because GPs will see patients in these categories. These are patients whom we wish to initiate thyroid replacement medications in. These are the patients in whom we're trying to achieve stabilization in, and some already stabilized maintenance. The issues that are always there is, how do we get to optimal dosing? What do we monitor and how often, and what are we looking for?
I think first of all, there is no set protocol of how you should do it. But let me put it in context. If you have a pregnant patient, then you want to ensure that they have optimal thyroid hormone replacement as quickly as possible, because each day, each week that goes by is critically important for brain development in the fetus. And if it goes wrong, you're not going to get another chance. And that child's going to have to live with that problem for the rest of its life. So we'll come back to that, but that's critical to get it right very quickly. At the other end of life, you've got the situation of the elderly patient who's not been doing terribly well, generally unwell. You, the doctor, have discovered the patient has hypothyroidism and want to start replacement therapy. Now, in most cases, the hypothyroidism will be mild. They're not in myxedema coma, which again is, the end stage of the disorder, which we could talk about if we have time. But most elderly patients will have comorbidities, most likely cardiovascular disorders. We all get arteriosclerosis with the passage of time. And I guess most of us, as we get older, we get some form of coronary heart disease. I think we have to be careful we don't suddenly change the metabolism as you would in a 25-year-old in an 80-year-old. So I think at that end of the scale, you are a lot more cautious and prudent the way you do it. So you start off with a low dose of 25 to 50 micrograms per day replacement. The average dosage you require for full replacement is 1.6 micrograms a kilogram body weight per day. You can quickly do your sums. If you're 60 kilograms, then that's around about 90 micrograms a day. You're 70, that's 130. I think if my arithmetic's correct, something like that. So you can figure out what the end result is going to be in that vicinity. Of course, that will depend on how much residual function is going on with that patient's thyroid. But that gives you an idea. So you can build up slowly over a period of months to get the dose right where you're not over-treating the patient. I think the most important thing is not to fill them up with thyroxine quickly and when you're going to over-treat them and possibly precipitate an episode of coronary heart disease, myocardial infarction, or an arrhythmia such as atrial fibrillation. So do it slowly, see how they feel, monitor their thyroid function tests at a 6-weekly time. And 6 weeks is an arbitrary figure, given on the basis that it takes about 6 weeks for the free T4 level in the blood and the TSH, pituitary TSH, to equilibrate. Probably equilibrates a bit quicker than 6 weeks, but somewhere between 4 and 6 weeks, you should measure that. So in the elderly patient, you're doing it slowly, you're monitoring them clinically. How do you feel? How are you going? You're monitoring their pulse rate, their blood pressure. You're monitoring their general well-being and body weight. You're monitoring their cholesterol, their TSH and free T4 levels. And you put that all together as we do in medicine, in most things we do, and reach a conclusion in conjunction with the patient. The other end of the spectrum, if you're younger and you're 25, 30, 40 years of age, you're otherwise fit, you've developed hypothyroidism, well, you can start them off on the full expected daily dose almost immediately. Go slightly under rather than go over. So if we take, again, the 60 kilogram otherwise healthy person developing hypothyroidism,
Mhm.
and they don't want to take time off work for doctor's appointments or whatever. It's safe enough to start them on near enough to their full daily dose. So I would start that patient on 75 micrograms a day.
Mhm.
It's a little bit under what I think will be the optimal dosage, but you get there more quickly. It's less costly. It's less time consuming for them. So you can make the judgment. Now, as I said when I started off, David, there's no set way of doing it, but I think those two methods, or three methods, going back to the pregnant one, are the acceptable ways of doing it. So let me come back to the pregnant patient. She's pregnant. You're doing your antenatal screening after the first missed period, and you are doing TSH screening, which my view is you should be doing that, and I'm well known to have that view, and you discover the patient is mildly hypothyroid. Well, you should initiate therapy immediately. So in that situation, you'd calculate their body weight and you'd go close to that dose that I've given you, 1.6 micrograms per kilogram body weight immediately. In other words, you're not going to take months to get there, because what you're treating is not just the woman and that obstetric history and obstetric event. You're treating the fetus as well, because that thyroxine that she's taking will cross the placenta and it will regulate growth, systemic growth, but most importantly, brain growth and maturation. So you've got to get it right as quickly as possible. So they're the sort of situations you find yourself in. I mean, there's variations if you're managing a young child with congenital hypothyroidism. I think that should be managed, by a pediatric endocrinologist, really, because there's problems with absorption and dosage, and they change with growth. So I think that's a very dynamic type situation, needs to be managed by an expert. Again, I think with pregnancy, I think the general practitioner obstetrician should call in an endocrinologist to manage that woman, and it should be seen as a matter of urgency. She's an urgent case, should be seen not tomorrow or the next day, but today if you can. That's the way you should manage it. So there's no one size fits all. It depends on stage of life, the clinical situation you're in, the comorbidities, and how you'd manage it.
Chris, that's very well put and very clear now. What about the degree of severity of the disease? Say, you mentioned a mild hypothyroidism to the more severe degrees. Does that impact how quickly we push up the medications?
Well, it does. I mean, if one took your thyroid out, I told you what sort of dose you'd need, you go straight to that dosage if you want, if you need to. If you have slowly developing hypothyroidism, you're producing a given amount of thyroid hormone. So and as you push the dosage up, you'd be turning off the TSH, that feedback effect, that negative feedback on pituitary. As the thyroid hormone, the free T4 level rises, it turns off the TSH. So your own secretion would decline. So it's that sort of balance that as you're pouring it in, taking the external amount of thyroxine in your medication, then your internal endogenous production would decline. So it's a bit of a balancing act. So when you're fully replaced, you're probably not producing any significant quantity of thyroid hormone because you've turned the TSH pretty well off. So it's an equilibration process.
This episode is one of hundreds of informative and free clinical podcasts from Health Ed. Access the entire library through the Health Ed app for healthcare professionals, which you can download today from the App Store.
Could I just go back to the woman who is pregnant and ask the question, what should GPs really be speaking to our women who are thinking about having a child? What sort of discussions should we have about the thyroid?
Well, I think the first discussion one should have with women of reproductive age, and they should be aware of it, but become not just aware, but take active change or intervention, is to ensure that you're getting enough iodine. It's like getting folate. So the two important micronutrients that a woman needs to take care of prior to becoming pregnant is folate and iodine. So if you're thinking you could become pregnant or you want to become pregnant or whatever, then I think you should start that well before you actually attempt to get pregnant. That's not the way the world works. You wake up one day, I guess, and as they say, 50% of pregnancies aren't planned. You find you're pregnant. So in that situation, then you need to ensure that you're getting enough iodine per day, because we know that we've now corrected iodine deficiency in the general population in Australia because we've mandated the use of iodized salt. I mean, all pretty well baked products have salt in them. And by law now, the bakers must use iodized salt. So that's bringing our intake up to normal recommended daily requirements in the general population. However, it's not enough for pregnancy, because in pregnancy, you need at least 50% more iodine to ensure an adequate intake, because you have to make more thyroid hormone, which you need for the pregnancy and you need to cross the placenta. So that's the first thing. The second thing is that if you have a history of thyroid disorders, for example, mother, father, aunt, uncle, grandmother has a thyroid disorder such as Hashimoto's disease, which can affect 10% of the population or thereabouts in Australia, or you are known to have thyroid antibodies, positive antibodies, or you've had a miscarriage, or you've had a goiter. If there's any suspicion of a thyroid disorder, then you should have your thyroid function checked before you get pregnant. And if you don't have that opportunity, then as soon as you get pregnant. Now, you should have thyroid stimulating hormone, TSH, done. My view is you should also ask for free T4. Now, that's not covered by Medicare, but if you write down the indication for it, in other words, why you've asked for it, it will be covered. And if there's any suspicion of underlying thyroid disease, you need to measure thyroid antibodies. You need to know early on, do I have underlying autoimmune thyroid disease? And, there's a 10% chance that a woman's going to have that. And if she does, then she needs to be managed very carefully. If her TSH level is raised, she needs to be given thyroxine replacement therapy. She needs to be monitored throughout pregnancy and into the postpartum. She may not need the thyroid hormone replacement in the postpartum. You can make that decision by monitoring. But the other thing is that she's at risk of developing postpartum thyroiditis. So if that woman turns up complaining that she's not well, not coping with the baby, life is difficult, she's depressed, anxious, or whatever, one of the first differentials in your diagnosis has to be postpartum thyroiditis. Overlooked, in my view, very commonly. So that's the way you would manage just to summarize, the woman that has normal thyroid function, never had a problem, no family history, make certain you're taking enough iodine to get through. The second, if you have a family history of thyroid disorders, autoimmune disease, Hashimoto's, Graves, or whatever, or you've had some other problem that may indicate possible underlying thyroid disease, then you must check. And that is a complete thyroid function check and measure thyroid antibodies. So I hope I've covered that.
You have just spoken about things that I had not even thought about, Chris. I have to confess that if a woman had come to me not coping postpartum, of course, we all immediately jump to postnatal depression. And you very quietly, and I think understated the fact that it has been overlooked, that we don't check the thyroid.
Well, I think it should be one of the first things you do. Because it is so common. And again, if she's had positive thyroid antibodies or previous thyroid disease or whatever, that's the first indication this is likely to be postpartum thyroiditis. But if you don't, it's like anything in medicine, if you don't think of it, you don't diagnose it.
Correct.
So I think, it should all be on our differential diagnostic list, rather than seeing some of these poor women suffering with the baby blues and being patted on the head or given antidepressants when very simply they've got postpartum thyroiditis, and that needs to be managed. We know how to manage it and we can manage it very well.
Well, thank you for putting that on our radar screen so firmly. You did also mention that we need to look for thyroid disorders in a woman who gives a history of miscarriages. Would you like to tell us a little bit more about that?
Yeah, this is one of the problems of one of the complications of subclinical hypothyroidism developing gestational hypothyroidism, in other words, developing during pregnancy, is that early miscarriage is a definite complication of that. There are multiple other complications we now know: hypertension, preeclampsia, eclampsia, all possible combinations. Not the only cause of thyroid, it's not the only cause of those problems, but it is a cause. It's a cause of small for gestational age babies, placental abruption, early delivery, and a child ending up in neonatal intensive care unit.
Mm-hmm.
So if a woman has any of those obstetric complications in a history and you take it, that also should convince you, I have to check thyroid function, and if in doubt, I have to monitor it.
Mm-hmm.
So I've given you a sort of background: a woman with previous thyroid disorder, a woman with a family history of thyroid disease. She may not know about it, except, well, Auntie Mary had a thyroid problem and took thyroid hormone, thyroid medication. That's all she may know.
Mm-hmm.
And that gives us a good handle that this is likely to be hypothyroidism. So if you have that obstetric history or family history or personal history, they're all clues for you to say, oh, this woman is at risk.
Yeah.
Now, why do we get very serious about this? We don't say, oh, well, it will work itself out, or we'll eventually get the diagnosis. You don't have time.
Mm-hmm.
Pregnancy takes 40 weeks, or it used to, I think, as I was taught. You don't have the luxury of time here. You have to make the diagnosis early, and you have to treat immediately.
Mm-hmm.
Because every week that goes by is potential for obstetric complications, for loss of the pregnancy, or if the fetus, the pregnancy goes to term or goes to a living baby, then that child may have intellectual impairment.
Mm-hmm.
So, it's in my view, it's an emergency that you have to do. You have to deal with it as an emergency.
Yes. Now, I have two issues about iodized salt in flour and breads. There are now groups of people now going to a lower carb diet, and also many institutions are pushing for us to consume less salt. How should we speak to our younger women about this if we know that they are both concerned about salt intake or are going for a low carb diet?
Well, there are a number of issues here. First of all, that most of the salt we get in our diet comes from processed foods. 80% or thereabouts
Mm-hmm.
is not what we add at the table or we add when we're cooking,
Mm-hmm.
but it comes from the processed foods. In other words, from the bread we eat. Bread's got a lot of salt in it. It's the ham and processed meals and whatever. So most of our salt comes from processed foods. And unfortunately, in Australia, our food manufacturers do not use iodized salt.
Okay.
Despite our attempts, they refuse to do so, and they'll give their reasons, which are mainly commercial reasons. They're not much more than that. So we're all being asked to reduce the amount of salt, which means we should be careful in what foods we eat, but also careful that we don't add salt at the table unless it's absolutely necessary, and we use the least amount of salt possible with our cooking. That's our first point. The second thing is that while we've reduced our salt in Australia and we don't buy enough iodized salt as it is,
Mm-hmm.
I go into the supermarkets and I see all these fancy Himalayan salts, which are
Mm-hmm.
basically crude rock salts coming from northern Pakistan, salt mines there, not the Himalayas. They don't have iodine in them. So we're not getting much iodine from the use of iodized salt.
Mm-hmm.
Most of our iodine comes from bread now and milk. And milk has been the source of iodine in our diet for 40 or 50 years, more than that. when the dairy industry took up using iodophores, which are disinfectants, using iodine as an antibacterial agent, and they use that in the dairy industry as teat dips, using it for cleaning out their milk cans and sanitizing them. Even the tankers, I believe, use iodophores. This was creating for us what I have used the term an accidental public health triumph.
Mhm.
We were getting our iodine from contamination of the food being dairy. What happened was that the dairy industry in the 90s started to change their practice for various reasons. One was cost. So they started using chlorine or hexadine sanitizers for one reason, because it was cheaper. And the other reason, they were concerned that they might be litigation, they might get sued for contaminating the milk with iodine. There may be side effects, adverse health effects. So we became iodine deficient in Australia. So, our problem has been, how do we fix this? And certainly after my own team did a national survey, this is when iodized salt became mandatory in bread and baked products. But as I keep saying, not enough for the pregnant woman. Particularly, she may eat less bread. She's not drinking milk or not eating seafood during pregnancy. She needs to take a supplement. So if we come back to the woman the younger women you were mentioning, those that think they're gluten intolerant or believe they are or really are, have got celiac disease, they're not eating bread and baked products. These women are often health conscious, so they're drinking almond milk and soy milk and oat milk. So if you go and stand in the line for your morning cappuccino, and these young women are all ordering their flat whites or cappuccinos or lattes, I feel like tapping on them on the shoulder and saying, hold on, you shouldn't be doing that. Now, because these women are going to be iodine deficient. They're putting themselves at risk. Even though they think they're doing the healthy thing, they're putting themselves at risk. So if that's the course of action they're taking in their lives, their decisions they've made, well and good. If that's the case, then it's absolutely critical that they consider taking an iodine supplement because they're going to be iodine deficient. I mean, when I say they're going to be, if you measure iodine levels in these women that are not eating bread and not drinking dairy, then they're going to be iodine deficient. I mean, I'm going to be 99% right on that. So you as a doctor should be taking a history to find out what their diet is like. And if you identify this deficit in iodine through these foods, then I think you've got to advise these women they should start taking an iodine supplement. So, I advise women that the simplest way of handling this is to go and buy a bottle of iodine and folic acid pills, which are pretty cheap, and take one a day. And that will protect them. Very simple, but that's the way to do it. Rather than attempt to change them and say, look, you shouldn't be having soy milk lattes and you shouldn't be drinking this or you shouldn't be doing that. You don't. You say, well, okay, that's the decision you've made. I know these are the consequences of that decision, even though you think that's the right thing for you. I'm not going to argue with you. But what I do know is that you'll be iodine deficient. You're putting your pregnancy and your baby at risk. So now you can get around that very simple way. You can fix that deficit by taking a supplement. This is the simple supplement. You can take iodine alone, or you can take iodine and folate. And in my view, that's the way to manage them.
Fantastic. And just thank you for filling in my area of deficit knowledge.
It's interesting, I think. We don't deal with some of these simple things the way we should at times.
Something you don't really give deep thought to, I'm afraid, Chris. Certainly I haven't. I only have these thoughts when you mention it, then these questions pop into my head. Now, look, it is really important. You did mention the myocardial infarction and atrial fibrillation in the elderly patient commencing thyroxine. Do we still cause atrial fib in patients that we start low and go slow anyway? And should we therefore be watching our elderly patients closely with regards to their rhythm?
The answer to your question is yes. The data suggests that there are a lot of older population and we're all getting older, and the average median age is is lifting year by year. That's a good thing for society. But what it means is that there's a lot of elderly patients that do suffer from atrial fibrillation and aren't aware of it. So I think you probably will be picking up people with atrial fibrillation that you didn't know had it, if you think about this as being a potential complication of excessive thyroid hormone therapy. And in so doing, you may well be saving some or many of these from adverse outcomes, such as a stroke. So I think you've got to be very careful. I think if you think along those lines, you will pick this up early if they've got atrial fibrillation and you wouldn't have otherwise picked it up. And also you'll pick it up with giving them thyroxine if you're monitoring them closely, and you'll back off with your medication. But you'll also recognise that they've got a cardiac problem. And I think you'll also turn your attention to investigating that cardiac problem and how you would manage their atrial fibrillation anyhow. Because if they're going to get, patients going to get atrial fibrillation as a consequence of their thyroid hormone medication, unless it's grossly excessive, then they have underlying cardiac disease that needs to be addressed.
Professor Eastman, I'm aware that we have a second interview with you looking at living with thyroid disease and patients taking medications. So I don't want to labor on this point with these elderly patients at the moment, but I must say I'm really grateful for your deep discussion on women who are pregnant and women intending to become pregnant. I thought that was an incredibly helpful discussion. So there seems now to be a lot of information that GPs need, and also informations that GPs need to give our patients. Where do we get these resources from?
Well, there's most of this, of course, is in the literature, but you've got to go searching for it, I guess. The Australian Thyroid Foundation, a not-for-profit organisation, is a significant and major source of information with regard to thyroid disorders. So just type in Australian Thyroid Foundation into your browser, your search engine, and it will turn up and you'll be able to find a doctor, and the patients can find a lot of information. They can also join the Australian Thyroid Foundation for a pretty small fee and have access to counselling and help and support if they need it. They can contact a counsellor within the Australian Thyroid Foundation or write to them with an email. And if they can't answer their question very easily, or it's an involved medical one, then it would be referred to people like me, I'm the principal medical advisor, or other experts on the medical panel. So they get great access to expert medical care, either written, oral, or ultimately in the form of an expert in the disorder. So I think from a patient's point of view and also from a GP's point of view, this is a good place to go. Second thing is that there are posters that I've certainly been involved with developing that are available for GP surgeries that can be obtained from New South Wales Health. So all one has to do is, again, go onto their website or phone and ask, can you have some of the posters relating to iodine nutrition and iodine supplementation in pregnancy. Now, they're good posters, they're attractive, and they're good to have in the doctor's surgery, and they're good to have in your rooms where you can use them to explain their situations to the patient. The third source, if the GP wants in-depth information, detailed expert information, there is an amazing textbook. It's online, it's free, and it gets thousands of hits per day, and it has about 30 odd chapters in it on thyroid disorders. It's called Thyroid Manager, all one word, .org. That's available online. There's chapters on everything from goiters and thyroid tumours and thyroiditis all the way through, and even down to quite elaborate chapters on iodine deficiency disorders, which I happen to give myself a plug in, which I happen to be the author of. But that textbook is accepted as the world leading textbook for doctors of whatever qualifications, if you want to check something out or to find references to a specific form of a thyroid disorder, you'll find it there. So I mentioned it again, thyroidmanager.org. So they're the main sources of information rather than having to try and keep up with the literature in specialist journals, because none of us can keep up with the literature across the board in all these things.
Mm-hmm.
But we'd like to be able to get to expert opinion if we need it very quickly. And I think you can do it through the sources that I've mentioned.
I'm just wondering to myself, Chris, in a sense, which patient will I not ask to join the ATF? Because it just sounds like they're going to have support, information, and help, and even internal referrals to specialists for tricky questions, I guess. So maybe it's up to us as GPs to encourage every patient who is on thyroid replacement medications to consider joining the ATF. It just makes good sense.
Well, I think it does. I think they're a wonderful organisation. The CEO, Beverly Garside, is an extraordinary person. She literally works, 10, 12 hours a day, or pro bono. She doesn't get paid for any of this. And she runs an excellent ship. She coordinates all these activities and ensures that the ATF keeps up to date with what's going on and responds to all these patients. And I can assure you there's some interesting and strange and tricky questions that come in by the day. There's always something new. And sometimes it makes the experts on her panel that answer these questions have to scratch their heads and go looking for answers. But that's good that they do that.
Well, I'm so glad you're there, because if you're going to have to scratch your head, I would have absolutely the snowflakes hope in hell of knowing it.
You're very kind.
So Creswell, I do thank you for the time and this effort in looking at thyroid medications and special particular groups to be careful of. And I would recommend all our listeners to look out for the next podcast from Professor Eastman, and that's on looking, and we'll be looking at living with thyroid disease. So for this moment, I thank you, Professor Eastman.
Thank you very much, David.
Thank you for listening. Visit healthed.com.au to create a free account and claim CPD for podcasts like this and access a record of your learning. Subscribe to the show on Spotify or Apple Podcasts for weekly episodes on a range of clinical areas relevant to your ongoing practice.